Thank you so much. Very good afternoon, everyone. And at the very outset, I would like to thank the organizing body of PTW on for having me here. And it's a delight that I've been introduced by Dr. Shobhan Goswami sir, who was my teacher. So, moving on, we'll be going through a few areas. It is why consider an early insulin initiation, how to manage it, how to take control, what is the importance of titration, and how to have a balanced approach between glycemic control versus hypoglycemia risk. So, to look at a few data, the reality is that 4 out of 5 people with type 2 diabetes are uncontrolled in India, and less than 1 in 4 Indians with established type 2 diabetes take insulin. Average HbA1c at which insulin is initiated in India is 9.2%. Even after insulin initiation, attainment of the HbA1c target is often inadequate. 8 out of 10 patients fail to get control. So we already know that what are the benefits of early insulinization, that is, the deaths are brought down by 21%, myocardial infarction is reduced by about 14%, and microvascular complications are brought down by about 37%. So this is a graph here. I don't have a pointer, but as you all can see, that is the first graph, which is marked by purple. The mean time spikes are high, and also the fasting is very high. So what is the purpose or relevance of fixed fasting first? The moment the fasting glucose is targeted and it is brought down, the entire graph starts coming down. So in order to have an effective glycemic control, we need to target the fasting glucose first, and once the fasting comes down with the glargine or any other long-acting insulin, we can target the mealtime ones also, accordingly with the bolus doses. Let's move on. So, if we fix the fasting first, the overall glycemic control is much better, because first the baseline comes down and then the peaks also are managed. Basal insulin takes care of the fasting plasma glucose, and the bolus ones take care of the postprandial glycemic control. Now, so glargine plus OADs with adequate titration can help patients achieve sustained control for greater than 2.5 years. Now, we know the legacy effect, that is early and aggressive control of glycemic levels is going to not only retard the progression of microvascular complications, but it is also going to keep them off for a long period of time. But the problem is what we face in our country or over the world, that in order to start an insulin, there is a lot of resistance, not just from the point of patients, but also from the point of physicians. There is lack of knowledge of diabetes and its effects. There is poor concordance with therapy, refusal to take insulin. Many of us take a very difficult time in our clinics to convince patients regarding the advantages of insulin and how to take it. And lastly, lack of insulin titration. So, in the UPPA's study, they have shown that what is the importance of achieving early glycemic control, which may generate a legacy effect, that is 24% reduction in microvascular complications, 15% reduction in myocardial infarction, and 30% reduction in all-cause mortality. Now, titration soon after insulin initiation is the key, because it's very important. We don't want spikes of hyperglycemia. We also do not want hypoglycemia, because hypoglycemia is equally detrimental for a patient as hyperglycemia. In fact, we might lose a patient very quickly also. So 80% of maximum treatment effect, that is HbA1c reduction, occurs in the first 12 weeks following initiation of insulin, and early response predicts long-term glycemic control with 12-week HbA1c levels maintained for up to 24 months. Similarly, early hypoglycemia doubles the risk of future hypoglycemic events, and early hypoglycemia increases the risk of treatment discontinuation. So once the insulin dose is started, titration is very important to achieve glycemic goals, and dose titration is patient-specific. We don't really have specific set of guidelines to follow. We need to keep in account the patient's HbA1c status, other coexisting morbidity, everything else, fear of hypoglycemia, whether the patient is educated enough, everything needs to be kept in mind while titrating the dose. Adequate titration, either by physicians or by the patient itself, can help the patients reach treatment goals, including HbA1c less than 7 and a fasting less than 100, which is our usual target. So there was this study which showed that in India, the average titration dose of basal insulin remains 18 units in practice, whereas in clinical trials, titration up to 40 units has also been reported. Like I mentioned, this variation is on a patient-to-patient basis. So, like I was saying, that initiation is not only a challenge, but titration optimization also remains a challenge, because say we start a patient with insulin, but after that, is the patient continuing? Is he or she being able to modulate the doses, or he or she is coming to us for regular checkups? If we eventually discontinue it within a very short span of time, then there is no point. So, fear of hypoglycemia, occurrence of daily episodes of hypoglycemia, blood glucose instability, and weight gain, lack of support, lack of education, and also, of course, in our country, cost of medications. These are few reasons why we are unable to achieve the insulin usage and the targets in the patients. So, like I mentioned, fear of hypoglycemia is a major barrier to insulin initiation and optimal insulin titration. For this, the only way is to educate the patients, to tell them about awareness of hypoglycemia, what are the symptoms of hypoglycemia, how they should be ready with anything that is available in our house. It can be glucose, sugar, candies, and then how important it is to alleviate hypoglycemia at that, or else it might even turn out to be fatal. So, fear of new hypoglycemia episode may lead to deterioration of glycemic control, because there is decreased desire of the patient for a tight glycemic control. The patient is afraid. So, if we set a target of a fasting of 100 to 120, or a PT target of 140 to 180, and the patient is having more and more episodes of hypoglycemia, he or she might reset the targets by himself or herself. They might just say, okay, today is 180, so I'm not going to increase my bolus dose. So what if I land up in hypoglycemia? So for that, there is reduced willingness to intensify therapy, poorer adherence to diet therapy, because they don't want to take or follow a rigid diet, because they feel that might again land them up in a hypoglycemia attack, eventually leading to compromised compliance with taking medication. Now coming to a balanced glycemic control versus risk of hypoglycemia, the same point that I have been reiterating, that we need a timely, effective and stable glycemic control, and the hypoglycemia should be avoided at all costs. Now, the right study, here we get a comparison between the U300 glargine. So, we have the usual glargine, that is the U100, and we have the glargine U300. So, basically, the units are the same, but the amount of glargine, when we inject glargine, it precipitates in subcutaneous tissue, and from there is a slow release. U-glargine 300, the amount is even lesser. So, the density is lesser, but the unit remains same. So, a comparison of glargine 300 versus IRED, they were comparable when it comes to glycemic control, and when it comes to nocturnal hypoglycemia and anytime hypoglycemia, that was reduced with glargine 300. And compared to regular and glargine, the HbA1c reduction was almost comparable between the two. Also, if we come to the anytime hypoglycemia versus nighttime hypoglycemia, that was also shown to have a better control in glargine 300 versus a premix composition of diabetic and aspartate. Now, coming to pregnancy. So, they have shown in the study that from 44 countries, cases were taken and 46 exposures were done. So, the rates of spontaneous abortions and congenital anomalies were low and consistent with the general population. That is where they came to the conclusion that use of glargine 300 during pregnancy was not associated with specific adverse events or congenital abnormalities. And the results suggested no safety issues with use of glargine 300 during pregnancy. However, in my personal clinical practice, I would beg to differ, because in newly diagnosed patients of gestational diabetes mellitus, I generally choose to prefer bolus and NPH insulin if required twice NPH. But if a patient is there of overt diabetes who is already controlled with glargine, I might choose to continue that. So, the discussion is that the subgroup analysis of the HUN study showed that in real-world setting, glargine U300 was effective at reducing HbA1c, fasting, SMPG with lower rates of hypoglycemia. And among those who titrate the titration upward gradually and continued beyond 12 weeks, and over time more patients achieve the target. The subgroup analysis suggested that insulin treatment should be individualized and treatment titration could be further optimized. So early initiation and adequate titration, avoidance of hypoglycemia is equal to optimal control. To summarize, insulin initiation is majorly delayed in India. Early and more appropriate interventions may improve patients' chances of reaching their goal. Achieving early glycemic control may generate a good legacy effect. There are no such definite guidelines at recommending the dose, but there is a unanimous conclusion to recommending basal insulin initiation at initiation. Timely intervention needs to be adopted to overcome therapeutic inertia. Early and more appropriate interventions may improve patients' chances of reaching their goal. Achieving early glycemic control is going to generate a good legacy effect. Glargine 300 is an ideal insulin that can be safely used for initiation and titration with a balance of safety and efficacy. Thank you for your patience.
Hello. Yes, it's a nice presentation, almost covering all the aspects. Only one thing I'd like to ask that we are going to have this 1 month long Ramadan. So Ramadan is a period when the food intake, that thing gets jeopardized, taking of medications, the timing gets jeopardized. So in brief, if you can say how to manage the insulin in those patients who are receiving for the month of Ramadan.
Thank you for the question. So during Ramadan, being the holy month of the Islamic calendar, and most of the patients who intend to follow the sacred month of fasting, and since the fasting is a very stringent one, it starts from dawn and ends at dusk, and they are not allowed to take any medicines, water, food during that point of time. So in patients of type 2 diabetes who are getting only basal insulin and tablets, if the patient is having a good glycemic control, HbA1c is in control, and he is going to follow all the norms, we generally reduce the basal insulin to about 20%, and we give the basal insulin, say around the evening, around 4 p.m. Because the patient is going to start his iftar, the dinner, and the sehri is going to continue the entire time. The chances of developing hypoglycemia is always during the last 3 to 4 hours of fasting. So glargine's timing duration of action being about 18 to 20 hours, if we give it around 4 or about 5 p.m. on the previous day, then the next day's hypoglycemia can be avoided and also generally reduced by 20%. If the patient is getting a sulfonylurea in addition to the insulin, then we reduce it to about 20%, and the morning dose of sulfonylurea is shifted in the evening around the time of iftar.